give rise to raised JVP. So if you're thinking, if someone comes into the casualty, okay, has had an accident, has had an injury on his chest, let's say it's a young boy, 25-year-old with raised neck veins, are you going to think cardiac problem? Probably. I'm not saying no, but probably not. But what he can have is a cardiac tamponade, okay, where there's blood around in the pericardial cavity, which is squeezing the heart, and that is causing the raised neck veins, rather than an organic problem with the heart. Any other condition causing raised JVP? Right, sir. Okay, that's a cardiac problem. Any non-cardiac problem? Hepatic failure, okay. I'm looking for something, I'm looking for one life-threatening condition. Comes usually clubbed with cardiac tamponade. Tension pneumothorax. Who said that? You. Very good. Okay. So if you see someone who comes with trauma to the chest and has raised neck veins, before thinking cardiac, start thinking, does the patient have a cardiac tamponade? Does he have a tension pneumothorax? These are life-threatening conditions. They will die in minutes if you don't intervene. Okay. Rather than getting an echo and checking their JVP and this and that, you need to do something about it. Okay. Fine. Anyways, let's move on. So JVP. So generally, if we look at the waveforms in JVP, so suppose we put a cannula in and we transduce this patient and we get a waveform of the pressures. Is everyone aware of this? AC, V, X, Y waves? Is everyone aware? Or no? Or if this is too much, tell me, I'll skip it. Is it okay for this? Okay, fine. I'll go very brief over this. So you have, whenever you see a jugular venous pulse waveform, there are 3 positive waves and there are 2 negative waves. So the 3 positive waves are A, C, V, and the 2 negative are X and Y. So what is A wave? So this is a continuation, obviously. A JVP look in the internal jugular vein, which connects to the SVC, which connects to the right atrium. So whatever waveforms you're seeing here, and there's no valves in these veins. So whatever waveform you're seeing here are direct kind of waveforms of the heart, you can say, so to speak. So A, so when the atria contracts, the right atrium is contracting, you get this A wave. Okay? So atria contracts, so it says atrial systole here. Okay, atria contracts, you get the A wave. And then it starts to relax until a time when the tricuspid valve closes, and then you get another small blip over here called the C. Right? Tricuspid valve closes, and then what happens? And then your heart, your atria starts to relax. When your atria relaxes, you get this big descent in pressure. So X wave is due to the atrial relaxation. A wave, atrial contraction, X wave, atrial relaxation. And what happens when the atria relaxes? It starts to fill with blood, right? So this V wave is when it starts to fill with blood, the pressure starts to go up again. It comes to here, V wave. And then eventually, there's enough blood in it, and it's time for the tricuspid valve to open. And the tricuspid valve opens, and the atria empties. So suddenly the pressure goes down again. Okay, so these are the 3 positive waves, and these are the 2 negative waves. AV, ACV, X, and Y. Okay? Now, this looks like a very busy slide. I just want, you don't have to sit and memorize all of this. I just want you to see this, the relation of the jugular venous pulse over here, A, C, V, X, Y, in relation to the cardiac cycle and in relation to the heart sound. So S1 is when the mitral valve closes. So when the tricuspid valves close, that causes the S1. You're aware of that, right? Everyone's aware of that? The first heart sound is caused because of the tricuspid, the atrioventricular valves close. And S2, which coincides with this part, is when the aortic, the semilunar valves, the aortic valve and the pulmonary valve, when they close, it forms the S2. So this is just to give you a relation between the pressures, the ECG, and the heart sounds in relation to the JVP. Okay? So how do you check the JVP? So you have your patient lying down at 45 degrees at the manubrium sterni. Okay? Does everyone know where the sternal angle is? It's When you look at your chest, it's a little bump over there in between your sternum. Okay, that's where the manubrium sterni joins with the body of the sternum. So put a scale over there, okay, and put one scale across. So wherever you see the upper level of the waveform, okay, that is what you need to measure. Okay, so put a scale here, put a scale across. Same thing here. Scale here, scale across. Okay, so this is the manubrium sterni. From here, you'll put a scale up, top of the venous pulsation. So if it's 3 centimeters, like it is over here, you always have to add 5 centimeters because that is the depth from the sternum to the middle of the atrium. So this 5 centimeters you have to add, and this 3 centimeters. So that is 8 centimeters of water, of jugular venous pressure. What is normal? Roughly about 9 or 10 centimeters of water. Okay? Fine. Again, the same things, AC, V, X, Y, S1, S2, and the ECG in relation. Okay? Now, why is all of this important? Why should we spend our time putting in these things and looking at the waveforms and talking about AC, V, X, Y? Is it important? With a cardiac patient? It can be important. It's not always important. In an emergency situation, if the patient is gasping, has got chest pain, don't sit and put your scale and this and that. It doesn't make sense then. Okay? But if you've got a relatively stable patient and you are assessing him completely, then you can do this. Okay? But why is it important? Because you can get an idea of what the diagnosis might be. So if you have someone with a complete heart block, you will get what you call cannon A waves, massive A waves. Because there's no correlation between the atria and there's no coordination between the atria and the ventricle. So your atria is contracting and the tricuspid valve is closed. What will happen? The gates are closed and the atria is contracting. Your A wave will go shooting up, right? The pressure will go very high. So you'll get cannon A waves. What about tricuspid stenosis? Again, tricuspidism is a narrowing in the tricuspid valve. So the A wave will go very high. Okay? What about in tricuspid regurgitation? There is no actual gate over there. So when the ventricle contracts, which is V, suddenly you'll get a big shoot in the pressure there. So anyway, you don't have to learn all this in absolute, you don't have to mug up all of these, but it will just give you an idea of what can happen. Okay, hence know these things. If you don't get all of this, don't worry. All I want you to know is if you see something like this, think that there might be a cardiac problem and get them assessed. Okay? Xanthelasma. For those who have never seen xanthelasma, it looks like this. Okay? You get these cholesterol deposits, right? Malar Flush will look something like this. Janeway lesions, these non-tender rednesses on their hand will look like this. Osler's nodes, bacterial endocarditis. You can get these tender kind of spots. If you see something like this, think bacterial endocarditis. Okay? Clubbing, another one with bacterial endocarditis. They'll get clubbing as well. Okay? Splinter hemorrhages. See something like this? Think splinter hemorrhages. Is this something like what you saw? Is this what you saw? When you saw splinter hemorrhages? Something like this. Okay. Now next. Now with regards to cardiac examination, things like inspection, palpation, percussion, they have a role, but the most important thing is auscultation. So with regards to inspection and palpation, I'm just going to run through, okay? So what do you look for? You look for things like visible pulsations. When your chest is exposed, have a look. See, where's the apex beat? Are there any visible pulsations? Okay, well, if you're seeing visible pulsations, what are you thinking? Could this patient have an aneurysm, right? Could he have some valvular heart disease, right? What kind of an apex beat is it? Is it a tapping apex beat? Is it a heaving apex beat, right? all are indicative of some kind of aortic valve disease. Okay? Are there any masses? Are there any scars? So suppose you see someone, an elderly gentleman, with a scar down the front of his chest. What are you thinking? He's probably had a CABG, or he may have had a valve operation or something. Okay, some kind of a heart operation. Fine? What about a permanent pacemaker? Where would you see it? Has anyone seen a permanent pacemaker? Yeah, where is it located? Where is it generally located? It's either over here, right? Just under the clavicle. Okay, so you'll see a kind of a box or a square kind of a thing underneath the skin. If you see that, or maybe on the right side even, okay? If you see that, what are you thinking? He's got a permanent pacemaker. Or he may have an internal cardiac defibrillator, an ICD, right? Fine. So this patient has probably got either some kind of a bradyarrhythmia for which he requires a pacemaker, or he's had some horrible arrhythmias for which he needs a defibrillator. Okay? Is there a precordial bulge? When will you see a precordial bulge? Suppose you've got someone with right heart failure. What kind of things will you see? Or pulmonary hypertension. Yeah, would you see a precordial bulge? You probably would, okay, depending on the grade of the pulmonary hypertension. Because the right ventricle, the right atrium, they're all quite dilated, okay? And they can actually present as a bulge. What about palpation? I've already mentioned about the apex beat. In case of aortic stenosis or aortic regurgitation, you can have a heaving apex beat. You can have a hyperdynamic apex beat, okay? Where is the apex beat generally located? In the fifth left intercostal space, in the mid-clavicular line. Middle of the clavicle, fifth intercostal space, that's generally where the apex beat is noted. If you have someone with left ventricular hypertrophy, it will shift, okay? So, look, just feeling for the apex beat, you find it's further down, start thinking, oh, does this patient have something that has caused him left ventricular hypertrophy, okay? It's not just one thing that will give you the diagnosis. It's the whole story, okay? So if you feel someone has, has got angina, syncope, dyspnea, then you feel that he's got a heaving apex beat, plus you find it's displaced, okay? It's all these little, plus you listen and you hear a murmur, okay? It's all of these little things that will point to the diagnosis, right? What else? So pulses we've already touched upon. Precordial heaves we've already mentioned. How do you check for a precordial heave? Does anyone know how you check for it? Amin? How do you check for it? So it's with the ulnar border of your hand, just place it next to the sternum over here on the left side, okay? If the patient has pulmonary hypertension, right heart failure, pulmonary stenosis, it will be heaving, okay? Now, generally in you and me, if we don't have those things, you shouldn't feel a kind of a heave over there. But if you do that, or we talk about diastolic shock. What is diastolic shock? It's a palpable second heart sound in the pulmonary area, okay? So if someone has pulmonary hypertension or right heart failure, the second heart sound, which is the closure of the pulmonic valve, you can actually feel it with your hand. How do you feel it? Place your hand in the second intercostal space, in this region of you. Just place it there, and you will feel the heart, the valves moving, so to speak. You'll feel some kind of a thrill, okay? Normally, you don't feel that. Try it on yourselves, you won't feel it. What about a thrill? What is a thrill? 5 minutes left. Oh, really? Oh, okay. Better hurry up then. Fine. So, what is a thrill? It's a palpable murmur. So if there's a murmur that is there, okay, then you can actually feel it. If it's so loud you can feel it, that's called a thrill. Okay. I'm going to move on a little bit quicker now because auscultation is the main part of your cardiac examination, and this is something that I want you guys to know about. So S1, S2 we've already talked about, normal heart sounds. There's something called S3 and S4 as well, which occur in the diastolic part. So between S1 and S2 is the systole, and S3 and S4 is the diastole. We'll talk about that. Murmurs, breath sounds, wheeze. So where do you auscultate? Number one, second intercostal space on the right side, your aortic area. You'll hear all your aortic heart sounds over here. 2, pulmonic area. Okay? All your pulmonary valve sounds you'll hear in the left second intercostal space, just next to the sternum. What about 3? 3 is an area called the Erb's point. It's the third left intercostal space. You'll hear especially things like aortic regurgitation you'll hear in these areas. Okay? 4 is the tricuspid area. It's the 4th or 5th left intercostal space. Somewhere in this region, next to the sternum, is where you'll hear your tricuspid valve sounds. And lastly is the mitral area, is the 5th. So S1, mitral and tricuspid valve close, heard in the mitral area and the tricuspid area. S2, aortic and pulmonary valves close, held at the left sternal border. Okay? Okay. Then S3 is the early diastole. So if you see your S1 and S2, this is the systole, and when the diastole starts, S3 is when the ventricle starts filling rapidly. Okay? And that causes an S3. This could be normal. In young teenagers who've had a long run and have come after an exercise, you might hear an S3, which is normal. S4 is a late diastolic filling. This is when the atria is pushing blood into a diseased ventricle. S4s are always abnormal. Okay? So normally you hear S1 and S2 in normal patients. If you hear all of these together, it's called a gallop rhythm, and that is abnormal. Again, just a pictorial view, aortic area auscultation, pulmonary on the left side, tricuspid at the 4th or 5th intercostal space beside the sternum, and the mitral area on the 5th intercostal space near the nipple over there. With the mitral area, the other thing is to ask the patient to lean to the left. Okay, you'll hear sounds better. I'm just going to go through 4 very common valvular heart diseases. Okay, aortic stenosis, aortic regurgitation, mitral stenosis, and mitral regurgitation. If you know these 4, then most of valvular heart disease is sorted out. So essentially, aortic stenosis causes a systolic murmur between S1 and S2. It's called a crescendo-decrescendo murmur. It's a systolic murmur. Okay, it's called an ejection systolic murmur. Okay, and it's harsh and saw-like, and you can often feel a thrill. Along with this, these aortic stenosis murmurs will often radiate to the carotid arteries. So when you hear a systolic murmur in the aortic region, auscultate the carotid arteries. Okay? You may find that you've got a radiation. If you think of that, then think aortic stenosis murmur. What about aortic regurgitation? What happens in aortic regurgitation? It's a diastolic murmur. So between S1 and S2, it happens after S2. Okay, and this is called a decrescendo murmur. It starts out loud and then tails off. Okay, a decrescendo murmur. Again, heard in the Erb's point, in the left third intercostal space. Okay, because the blood that goes into the aorta, it doesn't get stuck there, it keeps flowing back. Okay, auscultate at the Erb's point, ask the patient to bend forwards and listen. You'll hear it better. And it's generally a soft blowing kind of a murmur. It's not a harsh murmur, it's a blowing murmur. Mitral stenosis, very, very common in our country. Okay? So what will you have? You will have what we call a mid-diastolic murmur. Okay? And it's a harsh rumbling, a low-pitched rumbling kind of a sound, which happens after S2. Right? So this is your mitral stenosis murmur. Again, put him onto the left side, you'll hear it better. Mitral regurgitation. This is a pan-systolic murmur. It happens during the entire length of systole. Between S1 and S2, you'll hear a harsh kind of a murmur, a systolic murmur. Okay? How many of you have ever listened to murmurs for aortic stenosis or mitral stenosis? You've listened? Yeah? Next time you go, try and appreciate these things. Okay? So this is all of them together. So normal, first heart sound, second heart sounds. You may get a third heart sound. That's normal. Between 1 and 2 is systole. This is diastole. So aortic stenosis, early systolic murmur. crescendo, decrescendo. Mitral regurgitation, pansystolic murmur to the entire length of systole. Aortic regurgitation is a diastolic, an early diastolic murmur, right? Mitral stenosis is a mid-diastolic murmur. Fine? PDA is a continuous murmur, but never mind about that. Fine. We'll come to the end of, coming close to the end. So along with your assessment, nowadays, see, 50 years ago when we didn't have echoes, we didn't have ECGs, we didn't have coronary angiograms, everything depended on a clinical examination, which is what we talked about. But today, when science has advanced so much that things like inspection and palpation have a very limited role. Though still important, auscultation is much more important, but a lot of cardiac assessment nowadays depends on all of these investigations. Okay, so what are the basic investigations that you get done? The first three are very basic investigations. Anyone who gets a cardiac assessment will get a chest X-ray. Anyone will get an ECG. And many patients will get a 2D echo. Beyond this, if you're thinking of coronary artery disease, you'll get things like stress tests, cardiac enzymes, coronary angiograms, myocardial perfusion scans. I'm just going to talk a little bit about the top ones over here. So chest X-ray, this is what a normal chest X-ray looks like, right? Clear lung fields, this area over here, this is the aortic arch. This area is where the pulmonary artery will be. It's called the pulmonary bay. Okay, and generally the width of the heart is roughly about half of the entire width of the chest. That is normal. Okay, it's called the cardiothoracic ratio. Okay? But if you have a patient with CCF, congestive cardiac failure, what do you see? There's a lot of fluid in the lungs, right? Your heart enlarges, okay? And then these patients, generally, what do you tend to give them to reduce fluid? What have you, in your experience, what do you tend to give them? You give them a bit of Lasix, right? And they start peeing out lots of fluid. And you can hear creps and stuff. You can hear crepitations in the lungs, right? So you do all of that, and then the next day, the lungs clear out. So this is a chest X-ray of someone with CCF, given them some Lasix, cleared out, much better. Patient is less breathless, less crepitations. Someone with mitral stenosis will have an enlarged left atrium. They get something called straightening of the left heart border. Remember in the previous one I said aortic arch over here and a pulmonary bay? See what happens here. It's become convex. Okay? So the pulmonary artery is engorged and it's filling up this area. Okay? What about 2D echoes? 2D echoes have revolutionized cardiac assessment. Now we can see structurally what is going on in the heart. So if there's any structural heart disease, we will find out. So essentially it's putting a probe on the chest. This is a nice 4 cardiac chamber view. Okay, so you can put the probe over here at the apex and you'll see the right ventricle, the right atrium, the tricuspid valve between them, the left ventricle, the left atrium, mitral valve between. Just one of those things that you can do. Next, if you're thinking of someone with ischemic heart disease, what other assessments can you do? Coronary angiograms. So we put a wire up into the artery, either the femoral artery or the radial artery, go to the aorta, go through the coronary ostia. Remember I said in the beginning that you've got right and left coronaries? So when you put dye into the right coronary artery and take an image, this is what you should see. This is the right coronary artery. And if there's some blockages in it, then you can see it. The same way you put the cannula in the left coronary artery ostium, then this is what you should see. So this is the left anterior descending, and this is the left circumflex, and their branches. So if there are blockages, you can see. Another modality of investigation. I think that's it for cardiac assessment, really. Any questions? No one? Little boring, I know. Cardiac assessment is kind of boring. But the real fun starts when we talk about ECGs. That's where you'll get more interested, okay, and when we talk about group activity. The problem with cardiac assessment is most of it is done by investigation now, okay? But I wanted you to see things, especially the general examination and the auscultatory parts. Go home and listen to your patients with valvular heart disease, okay? Especially mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation, okay, and read up a little bit and listen to it. There's very little I can do on a presentation that will make you appreciate these things, but go home and see these things, okay? Fine. Thank you. Break now?
Thank you, sir.
Break now, or are we continuing straight away, or?
Sir, after the tea break.
After the tea break.
Sir, please be on the stage.
Okay.
Thank you, Dr. Prabhake Dasila, Director, MGM, New Bombay College of Nursing, to felicitate Sir with a memento.